In the next 30 minutes or so, I will review with you which vascular and cerebrovascular imaging tests are available when you evaluate stroke patients, which test to choose at what time, and what to expect. As you can see from this slide, the standard of care evaluation of acute stroke patient consists of history and physical, vitals such as ECG, blood oxygen, as well as basic labs, and quick access to structural imaging such as head CT, computerized tomography, or MRI, magnetic resonance imaging. In our center, we also prioritize these patients' access to non-invasive vascular ultrasound examinations such as transcranial Doppler, TCD, and carotid duplex ultrasound. And these non-invasive tests are used in our institution in part to select patients for invasive angiography, and catheter procedures are still being used in acute stroke, and in fact there are more technology being developed to help with invasive procedures to restore flow to the brain or to develop technologies that would allow secondary stroke prevention. So the goal of cerebrovascular imaging would be to select appropriate patients for appropriate therapy, and particularly those who require risky and invasive procedures. Next slide shows current standard of care treatment for patients who are stroke survivors or TIA. As you can see in the first few lines, it says aspirin, 81-325 milligram, Plavix, Agrinox. These are antiplatelet agents. Obviously, these agents would be prescribed based on findings on imaging that do not indicate hemorrhage in the patient. Other treatment options that are available mostly for secondary prevention in these patients are blood pressure control, diabetes control, statin medications to lower cholesterol. Additionally, there are some interventions available, such as carotid endarterectomy, CEA, particularly for patients with symptomatic greater than 70% unilateral internal carotid artery stenosis, or stenting in those patients. And then asymptomatic patients with greater than 60% unilateral stenosis may be considered for revascularization if they were given a chance of best medical therapy and there is still disease progression and so on. This is my more debatable area, but nevertheless that forms the basis for screening with cerebrovascular ultrasound for the presence of significant carotid stenosis. I did not put on this slide an emerging area of intracranial atheromatous disease that is particularly prevalent in Asia, but also can be found in the United States, particularly in southeastern population where I practice. And screening for significant intracranial disease is becoming one of the hot areas in application of cerebrovascular imaging. How about acute stroke treatment? Well, for stroke treatment, we have within 3 hours of symptom onset, intravenous TPA is approved as a frontline and the only approved therapy to reverse damage from ischemic stroke. Trials outside 3-hour windows are being completed, and up to 6 or even 8 hours there is an option of deploying intraarterial thrombolysis or combined approaches where first intravenous TPA is initiated and then followed by intraarterial rescue. At variable time window, one may apply newer devices for mechanical clot disruption or removal. Again, at the variable time window, there are new devices being tested for flow augmentation to the brain. We're still conducting some neuroprotective trials, although previous attempts were not successful. And up to several days, one must consider hemicraniectomy to save patients' life if they're developing malignant MCA syndrome or they develop really large and lesions in the cerebellar tissue. So given all these diverse treatments that one may administer, let's review indications for imaging and what imaging tests are available. So the main indicator for brain and head and neck imaging is, of course, stroke. The goal here is to rule out intracerebral hemorrhage or other types of hemorrhage, establish the diagnosis of this event, and give some prognosis for the patient and options for management. The hot new area of imaging is transient ischemic attack, and I will mention that when we will review appropriate tests. If you suspect arterial stenosis or occlusion, that's an indication to obtain some imaging. Traditional indication is also carotid bruit, and recently what has been scrutinized, who are the patients who did not have yet stroke or TIA, but require some assessment before surgeries, or high-risk vascular patient who should receive cerebrovascular imaging. Now let's start with the mainstay. The mainstay of evaluation of a patient with a stroke, particularly in the hospital, is a non-contrast head CT. The reason is it is universally available in the emergency rooms, particularly in the United States and developed countries. It is fast. It can be done within minutes with minimum loss of control of the patient. In fact, you can continue monitoring patient while in the CT scan. There are virtually no contraindications to non-contrast CT scan. It is considered the gold standard for ruling out hemorrhages. And contrast injection options are available. I'll mention some of them later during the talk. So whenever the patient comes to the emergency room and is being taken as a first test of choice to the non-contrast CT, remember that you may also request a contrast study at the same time if certain parameters are met that it would be safe to administer those contrast agents. So here is an example. This is the slide that's called non-contrast head CT showing intracerebral hemorrhage. And you can see here a bright area that is asymmetric. It's on one side of the brain. One is typical hypertensive hemorrhage on the left, and the other one is more cortical hemorrhage that represents event due to cerebral amyloid angiopathy. There are other types of bleeding. This is beyond the scope of this talk, but CAT scan sometimes is the first imaging test that patients with different forms of bleeding are receiving in the hospital. Disadvantages of head CT scan is mostly relates to interpretation of what's called early infarct signs. These are often vaguely defined, like 1/3 of the MCA territory, or what would you call certain changes in tissue besides hypoattenuation, besides hypodensity. That's what I would like to stress, that all early signs except hypodensity bear little, if any, prognostic significance for IV TPA within 3 hours of symptom onset. The major finding that I'm paying attention and trying to find on head CT is there hypoattenuation? Because the presence of hypoattenuation in a patient who is otherwise within 3 hours of TPA window makes me question the time of symptom onset. Quite often, history of present illness may not be ascertained in time, in a very few minutes of conversations. So finding hypoattenuation would question the time of onset, because it takes longer than 3 hours to form a significant infarction of tissue. CAT scan is being criticized as often being normal in acute phase of stroke and TIAs. To me, this is encouraging, because CAT scan shows somewhat tissue window, and if the patient has severe stroke and 4 hours elapsed and the head CT scan looks normal, that gives me optimism that this stroke may be not yet as severe to produce visible damage, and maybe this patient would benefit from some form of reperfusion procedures. The definite disadvantage of head CT is it is insensitive to small lacunar lesions or lesions in the posterior circulation. Now, switching to multimodal MRI scan, magnetic resonance imaging, including DWI, which stands for diffusion-weighted imaging, is that it is very sensitive to acute ischemia. Over 90% of strokes can be visualized readily right on admission, and it is also positive in about half of patients with TIAs. In fact, MRI is now recommended as the preferred imaging modality for patients with resolved symptoms such as TIA, because you can prognosticate the risk of TIA recurrence based on presence or absence of lesion on DWI and presence or absence of a vascular obstruction on MR angiography or MRA. MRI is also sensitive to posterior fossa and lacunar lesions. It is helpful to differentiate acute from subacute or chronic lesions through ADC maps, flares, and other sequences. It demonstrates topography and mechanism of cerebral ischemia, providing wealth of information of what kind of damage you will be dealing with in any particular patient. Next slide details disadvantages of MRI. It is not universally available for urgent workup. In fact, even in large hospitals, still, MRI is not necessarily available in the emergency room, or transfer from the emergency room to MRI may actually take long time. The other issue is loss of contact with the patient, because it takes longer scanning time. Scanners physically require patient go inside the scanner, so you kind of lose direct visual contact. And if you want to obtain all sequences that are required for complete stroke workup, it will take a considerably longer time, probably in the order of about 30 to 40 minutes to complete all sequences. Putting together transport time, patient preparation time, and going through a long list of contraindications makes MRI practice in acute setting rather difficult. Not impossible, but difficult. And contraindications need to be kept in mind. For example, presence of metal or certain devices like pacemaker. Patients may be claustrophobic. Patients may be unstable to go for a prolonged time laying down flat inside the scanner. Now, there are certain aspects of MRI that require expert interpreter. For example, detection of hyperacute hemorrhage or old microbleeds requires some training. It is not to say that CAT scan doesn't require that. They both require that, but MRI requires training in more pathologies, as it is able to visualize some conditions that CAT scan isn't sensitive to. And we just started finally to fill the gap on objective criteria for imaging that need to be validated in randomized clinical trials. There is an acute imaging map, roadmap right now, worked out. There is several clinical trials being completed that use advanced imaging techniques, and the data will be emerging as to which parameters of MRI or advanced CT would be the most helpful in decision making. Meanwhile, the mainstay is to identify hemorrhage, and after you ruled out hemorrhage, to quickly visualize tissue that's salvageable.